Hello friends, so this is the third video in the series of neurocutaneous syndromes. Today we'll be talking about two important NCS, which is VHL, that is von Hippel-Lindau syndrome, and SWS, which is Sturge-Weber syndrome. So let's begin with von Hippel-Lindau, which is also called familial because it's hereditary, cerebelloretinal because these are the major organs involved, angiomatosis, which is the basic pathology or the pathophysiology which happens in VHL, that there is abnormal angiomatosis or angiogenesis which occurs. So it's also called familial cerebelloretinal angiomatosis. Again, it's an autosomal dominant syndrome like NF1 and 2 and tuberous sclerosis. It's also autosomal dominant. It is quite rare compared to the other neurocutaneous syndromes with a prevalence of 1 in 35,000 people. Now, coming to the most important part, which is the genetics. So, VHL is the gene which is deleted in the syndrome, that is VHL. So, VHL is the name of the gene and it is a tumor suppressor gene which is located on chromosome 3p. Now, 3p is important to remember. It can be asked as a direct one-liner in NEET or DNB exams. So, 3p for VHL is an important gene you need to remember. Now, what does VHL do? So, VHL, that is the protein that the VHL gene codes for, is a primary regulator of HIF, which is hypoxia inducible factor. Now, this is very, very important. You need to know that HIF is negatively controlled by VHL gene. Now, what happens is HIF in turn regulates all these proteins, that is PDGF, VEGF and TGF, which are nothing but growth factors and cytokines which control angiogenesis or vasculogenesis. So, it's very important that VHL, when intact, negatively controls angiogenesis, that is, it inhibits angiogenesis. So, whenever VHL is deleted in this syndrome, there is uncontrolled excessive angiogenesis or vascular proliferation which goes on in various organs of the body, most importantly, as the name suggests, cerebelloretinal. Now, clinical part. So, most patients are symptomatic as young adults. So, they have a later presentation. As we have seen in tuberous sclerosis, NF1, the patients will present quite early on as children. However, in VHL, there is a later presentation as young adults. Now, what is the initial symptom, which is the most common initial symptom? So, the answer to this is painless visual loss. फिर से ये कर लेती हूँ. Now, what is the most common initial symptom? So, the most common initial symptom is painless vision loss from retinal angiomas which will induce hemorrhage. So, retinal angioma induced hemorrhage leading to vision loss, which is painless, will be the most common presenting symptoms. Most common presenting symptom in patients with VHL. Now, to better understand the pathophysiology, which is very, very important, as I've already said, VHL inhibits HIF, which is hypoxia inducible factor, which in turn controls VEGF, PDGF and TGF alpha. So, again, like we discussed in TSE, where we saw that mTOR inhibitors are used as treatment because mTOR is the protein which is the central part of tuberous sclerosis. Similarly here, when we have tumors or lesions which cannot be operated upon by surgery, what we do is we go for medical treatment, and the medical treatment is directly related to the proteins that we are seeing here. So, sunitinib and sorafenib are drugs which will inhibit VEGF receptors and PDGF receptors. So, these receptors or these proteins will be blocked by these drugs, and again bevacizumab, which is a VEGF and monoclonal antibody. So, these drugs will directly inhibit these proteins which are crucial steps in the pathophysiology of VHL syndrome. Again, mTOR comes into play here as well. So, mTOR again influences HIF, and if we use mTOR inhibitors, they will have an effect in VHL as well. So, these are the drugs which have a role in VHL when the tumors or lesions are unresectable. This pathophysiology is very, very important for you to understand. Now, coming on to the main part, that is what are the lesions which come under VHL. So, starting with CNS neoplasms and visceral lesions. This is a table which is taken from Osborne's Brain Imaging and Pathology, which is a standard reference textbook for brain radiology. So this is a table which is describing the various manifestations that we can see in VHL. First of all, CNS neoplasms. So what are the two main important lesions in the brain? First of all, hemangioblastoma, which is the most common as well as the pathognomic lesion of VHL. These hemangioblastomas are seen most commonly in the intraaxial location, that is within the brain, in the infratentorial location, and the most common location is cerebellum. Apart from cerebellum, these are also seen in the spinal cord. So cerebellum and spinal cord are the two main locations of CNS hemangioblastomas. A sub part here is also retinal hemangioblastomas or retinal angiomas. And we saw that this is the most common initial presenting symptom that patients will present with painless vision loss because of bleeding induced by these retinal angiomas. So these are the first and the pathognomic lesions of VHL, that is hemangioblastomas. Next CNS neoplasm is endolymphatic sac tumors. As the name suggests, the location is endolymphatic sac. If you can recall, it's a part of the inner ear. So the endolymphatic sac of the inner ear will produce these destructive, highly aggressive lesions, which are in short called ELSTs, that is endolymphatic sac tumors. Coming on to the visceral lesions. First of all, renal lesions, which occur in 2/3 of all VHL patients. First is renal cysts and the second is RCCs, particularly of the histopathological type, clear cell RCCs. So RCCs and renal cyst will occur in VHL. Now, just to go back to tuberous sclerosis, if you can recall, there were 3 renal manifestations that we talked about there. 2 of them were common. So one is renal cyst, one is RCC. But the pathognomic feature there was angiomyolipomas. So again, remember that if you see RCC and renal cyst, you must look for these fat containing lesions which appear black on CT called AMLs. If they are there, think about TSC. If you're not seeing AMLs but you're seeing RCC, renal cyst in combination with other of the manifestations of VHL, think of VHL. So these were the 2 renal manifestations. Next is adrenal pheochromocytoma. Now pheochromocytomas are very, very important and they are a hallmark of type 2 VHL. This is not very important, but just for completion's sake, you need to know that there are 2 types of VHL based on the type of mutation. Type 1, the hallmark is CNS lesions and Pheos are characteristically absent there, whereas in type 2, Pheos will be seen. So this is just a brief extra point that you need to know, that type 2 VHL, the hallmark will be pheochromocytomas. Coming on to the pancreas. Pancreatic cysts, again like kidney, there will be cysts in the pancreas. There will be non-secretory islet cell tumors or NETs. NET stands for neuroendocrine tumors. So this is the latest name for these tumors, which is neuroendocrine tumors, and they will typically be non-secretory islet cell tumors. Next, we will see cysts in other parts of the body like epididymis. So epididymal cysts and cyst adenomas are quite common and they will often be bilateral. So if you are given a case scenario where the patient or a young boy is coming with bilateral epididymal cyst adenomas, always think of VHL. Again, a counterpart in females will be broad ligament cyst adenomas. However, this is quite rare. So this is a complete list of the various manifestations that are seen in VHL. Now, what constitutes the diagnostic criteria? When will we label a patient as VHL? So here there are 2 pointers. Is there a family history of VHL? If the answer is no, you need to either have 2 or more CNS hemangioblastomas, that is either in the cerebellum or spinal cord or both, or retinal feature, or there is one CNS hemangioblastoma in one particular location plus a visceral tumor, as we saw, either a pancreatic tumor, a renal cell carcinoma, or a pheochromocytoma. But if there is a positive history, so then our index of suspicion will be quite low. So first is any one CNS hemangioblastoma if we see, we'll straight away go and diagnose the patient as VHL if there is a positive family history. Any Pheo in the patient with family history of VHL, diagnosis of VHL, or a clear cell RCC. So any of these lesions which are pathognomic for VHL, if we see in a patient with positive family history, we do not need any other feature to diagnose him or label him as a case of syndromic association of von HippelLindau. Now, very briefly, we'll look at a few images and better understand the manifestations that we've already listed. So first, we'll talk about the CNS features. So the first is hemangioblastomas. Now, as I've already told you, cerebellum or the infratentorial location is the most common site of hemangioblastomas. As you can see in this schematic diagram, again the reference for which is Osborne's imaging. So here we can see that there is a highly vascular lesion. As we talked about in pathophysiology, VHL centers around uncontrolled vasculogenesis. These are all very vascular lesions. So here you can see this lesion in the cerebellum, a similar lesion in the spinal cord. So these are the two most common sites of hemangioblastomas. Now on imaging, that is CT or MR, when you've given contrast, in a contrast enhanced CT or MR, what you will see, the typical appearance is called a cyst with enhancing mural nodule. So this is the typical feature or the imaging description that is given for a hemangioblastoma, typically for a cerebellar lesion. So we'll be seeing a cystic lesion and there will be one enhancing nodule in the periphery mostly, which is showing enhancement with contrast in either CT or MRI, better obviously appreciated on MRI. So this particular description of cyst with mural nodule is quite typical for hemangioblastoma, but it is not specific. It is also seen in tumors like pilocytic astrocytoma, again the location for which is cerebellum. So in cerebellum, if you are seeing a lesion that is cystic with a mural nodule, straight away ask the age of the patient. If the patient is a child in the first or the second decade, the answer will be pilocytic astrocytoma. Whereas if you have an adult and there are other manifestations of VHL, think of hemangioblastoma. So that is how you distinguish based on radiology as well as clinical correlation. Coming on to the next hemangioblastoma, that is the retinal hemangioblastoma or retinal angioma, which is bilateral in 50% of the cases. Now this is an image of the fundus in a patient with retinal angiomas. You can see that these are the normal vessels, whereas if you see here that this is the retinal angioma and the arteries which are feeding it are quite tortuous. So this is a typical fundus image of retinal hemangioblastoma or angioma. And again, to re-emphasize, this will be the first initial symptom in most cases. That is painless vision loss induced by bleeding from retinal angiomas. The next CNS feature, which is not very common but is seen in almost 10 to 15% of the cases, is endolymphatic sac tumor. So here in this schematic graphic diagram, you can see that this is the location of the inner ear. So this is the eustachian tube. These are the mastoid air cells. This particular arrow here is showing the sigmoid sinus. This is the vestibulocochlear nerve which is entering the inner ear, and just behind and lateral to the nerves, we are seeing that there is this vascular aggressive sort of lesion, which is nothing but the endolymphatic sac tumor, and is located here in the location where normal endolymphatic sac is located. So here you need to remember that this is a very aggressive vascular lesion. This is again a CT image. How do we know it's a CT image? As I've talked about in many of my earlier videos, look at the bone. So here if you see, these are the bones. These are all white. So these appear white on CT scan, whereas they appear black on an MRI. So this is a CT scan image. These are the two orbits. So this is the globe. This particular line here is the optic nerve. These are the extraocular muscles. Now this is the normal side. Now if we compare it to the other side, what we are seeing is that the entire globe appears white. Now what is white on a CT scan. A lot of things are white. It can either be contrast, but if this is a non-contrast, if I tell you this is a non-contrast scan, the first thing that will come to your mind is hemorrhage. So hemorrhage, particularly acute hemorrhage, will be bright on NCCT. Apart from that, as we can see, bones will be bright. So either bones, iodine or acute hemorrhage will appear bright on NCCT. So what is going on here is that there is acute bleeding within the globe induced by a retinal angioma in a case of VHL. So this is the NCCT appearance of that. Here again what we are seeing is, first of all, going back to the basics, these are the bones. This is a CT or an NCCT. What we see here is, what are these black lesions? So what is so black, so dark on a CT scan? The answer is air. Still dark but not as dark as air? The answer will be fat. So the darkest here, that is pitch dark, as you can see here, this is the sinus, sphenoid sinus, which is filled with air. That is why it's so black. These are the mastoid air cells. This is the middle ear, which is all filled with air, and that is why appearing black. Now, when we are seeing this particular lesion, what we are seeing is that there is this irregular spiculated destruction of the bone which is going on here because of a highly vascular tumor, which we know is endolymphatic sac tumor, which is located just medial to the mastoid air cells. This particular structure here is the cochlea. This particular lesion or the canal here is the internal auditory canal, and the lesion which is located in the retrolabyrinthine location, typically described as retrolabyrinthine location, is the ELST, which is endolymphatic sac tumor. Next, again, we'll see images for the visceral manifestations. Just to re-emphasize and recall, the renal manifestations, RCC, typically of the clear cell type, and renal cysts are the two renal manifestations. Here, this is again a CT scan. You can see that the vertebral bodies, the bones are white. It is a contrast enhanced CT scan because you can see that the kidney, these are the two kidneys here. We can see that the cortex is quite white, suggestive of enhancement by the cortex because of the contrast we have given. So this is a CECT, and it is a coronal image because we are seeing kidneys in plane like this. It's a coronal image with contrast enhanced CT scan. What we are seeing here is that this is the normal kidney on the left side. On the right side, what we are seeing here is that there is a tumor. There is a tumor which is replacing the upper pole of the kidney, which has quite a heterogeneous appearance, and this is nothing but a clear cell RCC. Now, one more important fact to remember here is that RCCs is usually one of the most common causes of death in patients with VHL, and because they have a higher tendency to develop renal cell carcinomas in both kidneys, the patients will undergo partial nephrectomy. So this is one important indication of partial nephrectomy, that is VHL. Now, what are the other visceral manifestations? As you can see in the schematic diagram, these are the two kidneys. We can see that there are multiple RCCs, there are multiple renal cysts which are developed. Apart from that, this is the pancreas. In the pancreas, what you can see is that there are multiple pancreatic cysts which you can see here. Also, there will be NETs, which is not shown here. And what you can see here in the adrenal, so this is the normal Y-shaped adrenal on the right side. However, on the left side here, what we can see is that there is a tumor which is nothing but the Pheochromocytoma. So this is a nice schematic showing all the visceral manifestations of VHL. Coming on to a more detailed description of Pheochromocytoma. We all know the rule of 10. What is the rule of 10? That bilateral tumors occur in 10% cases. 10% of the Pheos will be malignant. 10% of the Pheos will be extraadrenal. And what is the most common site of extraadrenal Pheos? The answer to that will be organ of Zuckerkandl, which occur in the retroperitoneum. The other thing is 10% of the Pheos will be familial. However, this used to be an old concept, and now they say that 25% of the Pheos are familial. So now remaining 3 things for rule of 10 include 10% are bilateral, 10% are malignant, 10% are extraadrenal, and the most common site of extraadrenal Pheos is organ of Zucker-Kandel. What is the classic triad of clinical features we all know? Paroxysmal headache, that there will be sudden onset of headache, palpitations and perspiration. So there will be a triad of these 3 things will occur suddenly in patients, which is headache, sweating and palpitations. What is the what is the investigation? That is the most sensitive investigation are plasma catecholamines and VMA levels, which are metabolites which occur when Pheos will overproduce the hormones, that is adrenaline and noradrenaline. What is the nuclear medicine investigation which is used for Pheo? The answer will be MIBG scan. So MIBG scan is quite useful to pick up extra adrenal lesions, particularly in patients with syndromic association. So MIBG scan will be a whole body scan which will pick up even small tumors which are secreting these hormones and will be very sensitive. Now, what is the imaging appearance or the CT appearance of pheochromocytoma? So, this particular image here is again a CECT axial section. What we are seeing here is that this is the liver, this is the spleen, and this is the stomach, which is grey because of fluid. What we are seeing here is that there is a very bright round lesion which is located here, where we would expect a normal adrenal gland which will look something like this to be sitting here. Now, instead of this, what we are seeing is that there is an intensely enhancing. It is very bright because of the contrast it has taken in. So, it is intensely enhancing lesion which is located in the left suprarenal or the left adrenal location, which is very typical for Pheo if you are given this particular clinical history. So, always for Pheo, although the imaging features are quite typical, you always associate it with the clinical features and the plasma levels of catecholamines, VMA, and also if in doubt, you go for a MIBG scan to confirm your diagnosis. Next, on an MRI. So, on MRI again, so this is an MRI. How do you confirm? If you look at the ribs, they are dark, right? So, this is an MRI, whether it's a T1 weighted or a T2 weighted. So, you look at the spinal cord here, right, and the CSF is bright. So, this is a T2 weighted MRI image, and what you are seeing here is that in the location of the suprarenal gland on the right side, we are seeing a T2 bright lesion. So, this is called the light bulb sign for pheochromocytoma. So, the light bulb sign on T2 weighted image, that it appears very bright like a light bulb, is also again a specific radiological feature for pheochromocytomas. Now, what are the various syndromes associated with pheochromocytomas? This can be asked to you in AIIMS or NEET as a all except question, that all of these syndromes are associated with Pheo except. Now, what are the syndromes which are associated? NF1, VHL that we are talking about right now, MEN2 syndrome, Sturge-Weber, which we will be talking about next, and Carney's triad. So, these are the 5 syndromes or familial associations that are associated with pheochromocytomas. Now, what is the Carney's triad? Carney's triad is a triad which consists of GISTs, that is gastrointestinal stromal tumors, Pheo, pulmonary chondromas, Pheos or paragangliomas, right? So, this is the Carney's triad, which is GIST, paraganglioma / Pheo and pulmonary chondromas. Now, moving on to the other visceral manifestations, that is pancreatic manifestations. As we have discussed, there are 3 particular manifestations, cyst and NETs, that is neuroendocrine tumors being the most common. One more feature here is serous cystadenoma, which is a cystic tumor of the pancreas, typically occurs in old females in the head of pancreas, and there are microcysts within the lesion, and there is a central stellate calcification. So, These are the typical features of serous cystadenoma in a normal patient. In VHL, however, the onset of serous cystadenomas can be earlier. So, they cannot occur so late, which are normally associated in elderly females. They are typically called grandmother lesions because they occur in this age group, but in VHL, they can have an earlier presentation. So, the typical radiological appearance will be cystic or microcystic appearance with multiple small cysts, and will be central stellate type of calcifications, and they typically occur in the head of pancreas. So, these are a few words about serous cystadenomas. So, these are the three important pancreatic manifestations. Now, this is not very important for you to remember, but just keep in mind that what are the screening recommendations for patients in VHL. Because there are particular guidelines, I am talking about them here, whereas for other syndromes, they are not well published guidelines. So, what are the screening recommendations in patients with VHL? They will undergo annual screening, that is ophthalmoscopy for retinal angiomas, physical and neurological examinations beginning in infancy or early childhood if there is a known family history. Brain MRs to rule out hemangioblastomas and ELSTs will be done every 1 to 3 years, and they will be started in adolescence because that is the usual time when these tumors will present. Abdominal MR or ultrasound screening, particularly for the two most important lesions, that is RCC and pancreatic NETs or cystadenomas, usually begin at the same time in adolescence around the age 16. Because the cysts are not very pathological, they won't cause a lot of symptoms. It's not very important to screen for them, but the other important lesions like RCC, pancreatic tumors, Pheos will cause a lot of clinical symptoms and can turn malignant. So, they need to be screened. For Pheo, what are the methods? So, there are multiple methods of screening for them. It can be a clinical examination where the blood pressure is monitored, a 24-hour urine catecholamine examination, and as we know, type 2 VHL have a higher predisposition for Pheo. So, if the patient has a known family history of type 2 VHL, we will strongly screen for Pheo rather than the other tumors. So, these are the screening recommendations in patients with VHL. So, these were a few things and a few manifestations of VHL. Broadly, for VHL, what you need to remember here are two things. One is the basic pathophysiology, where the chromosome 3p is where VHL gene is there, and when VHL is deleted, what goes on is uncontrolled stimulation of HIF, in turn leading to uncontrolled stimulation of VEGF, PDGF and other TGF alpha, other proteins, which in turn lead to uncontrolled excessive vasculogenesis. So, these vascular tumors will result from this pathophysiology. So, this is one thing that you have to remember. The other thing you need to remember are the various manifestations from head to toe. So, in CNS, we talked about hemangioblastomas and ELSTs. Most common site of hemangioblastomas was cerebellum, and the few visceral manifestations, the most important of which are three organs: kidney, pancreas and adrenal. In kidney, we remembered clear cell RCC and renal cysts. In adrenal, pheochromocytomas are very important. In pancreas, there are again three manifestations, that is pancreatic cysts, neuroendocrine tumors and cystadenomas. So, these are the various manifestations head to toe of VHL that you need to remember. You can be given a case-based scenario or you can be asked directly. We also saw a few things in detail about pheochromocytoma and RCCs that you need to remember. Now, moving on to the next syndrome that we want to talk about is Sturge-Weber syndrome. This is also called encephalotrigeminal angiomatosis. Again, this is an angiomatosis syndrome like VHL, that there is vascular proliferation and vascular tumors which occur. And what are the two sites which are predisposed? Encephalo, again brain, and trigeminal, because the trigeminal distribution, the distribution of the trigeminal nerve is particularly affected, as we will see as we go on. Now, the most important thing that you need to remember, even if you don't remember any manifestation, you need to remember this is not inherited, it is a sporadic syndrome. It is not autosomal dominant like the other neurocutaneous syndrome. it is sporadic in origin. So this is very, very important and a straight one-liner that has been asked multiple times in NEET exam. So what is the genetic mutations? Now this particular syndrome remained an enigma for a long time. Nobody knew what was going on. Recently what has been proposed is that there are these post-zygotic somatic activating mutations. Because they are not inherited, they have proposed that it's a post-zygotic somatic mutation in the gene which is GNAC. So this is the gene which is proposed that is mutated in Sturge-Weber syndrome. What happens is, again, there is hyperactivation of several downstream pathways which include RAS pathway and mTOR pathway, which all comes down to the same thing that we've been talking about in all the neurocutaneous syndromes. So we talked about RAS when we were talking about NF1, mTOR we've talked extensively in tuberous sclerosis and VHL. So these same pathways are also affected in Sturge-Weber syndrome, but the culprit gene here will be GNAQ, GNAC gene. Now what are the manifestations? Now it has very few and very pathognomic typical manifestations which happen in Sturge-Weber. The first of which is what is famously called the port wine stain or nevus flammeus, and this is a typical image spotter that will be given for port wine stain or when the examiner wants to take you towards Sturge-Weber syndrome. Now what is it? It's a dermal, capillary and venous malformation. So it is not a high flow or an arterial malformation. It's a low flow, capillary and venous malformation which happens in the dermis. So it's a dermal, capillary, venous or a low flow malformation. It occurs in the trigeminal distribution. Now this is very, very important, that what is the most common site of these port wine stains. So they say V1, V2 as the most common site, but if asked one, the answer will be V1, that is the ophthalmic area. So the ophthalmic distribution of V1 nerve will be the most common site of these port wine stains, and also V2. So the entire trigeminal distribution unilaterally typically will be involved in port wine stain. It is seen at birth and it is absent in 5% cases. So it's not that it's present in 100% of the cases of Sturge-Weber. It can be absent in 5% of the cases as well. What are the other manifestations? Now the other manifestation is pial angiomatosis. As the name was angiomatosis, what happens here is that if you can see in this schematic diagram, which is again taken from Osborne's imaging, this is a magnified image. What happens is that this is the cortical surface of the brain, this is the pia, this is the pial matter which is lining the grey matter, and what is happening here is that there is proliferation of these vessels. So there are these pial collaterals or pial vessels which develop in Sturge-Weber syndrome. That is why it's called pial angiomatosis. Also what happens here is shown in this arrow is that there are these deep medullary veins which will develop and enlarge, and this is the choroid plexus which will also enlarge. So there are three things which are enlarged. There are these pial collaterals, there are these deep medullary veins or venous collaterals, and there is choroid hypertrophy or choroidal angioma, as you might want to call it, that occur in the brain. Now what happens is there is unilateral cortical atrophy because of venous infarcts. So because of venous infarcts, as the patient grows older, there is this unilateral cortical atrophy which goes on, and the most common location of it is parieto-occipital region, and again it is unilateral and the atrophy is in the same side as facial nevus. So the cortical atrophy and the facial nevus will be seen on the same side, and as it goes on, what happens is, along with the cortical atrophy there will be this typical gyral calcification which will occur. So the gyri, that is, so this is the normal side, so these gyri will undergo calcifications on the abnormal side. I am just showing you here so that you can appreciate it better. So these gyri will undergo calcification on the abnormal side which is undergoing atrophy. So these are the CNS manifestations. In short, what you need to remember here is that because of gyral calcification on a skull X-ray, what you see is this typical appearance which is called the tramtrack appearance of skull, which is pathognomic for Sturge-Weber syndrome. So tramtrack gyral calcification, which is appreciated on the skull as tramtrack calcification, is seen in Sturge-Weber. This is just a gross specimen which are showing these pial collaterals and cortical atrophy on the affected side. Again, this is a CT image. How do we know? So this is the CT because the bones are white. What is this white structure? So what appears white? We saw three things: bones or calcification, contrast and hemorrhage. So this is not hemorrhage, this is not contrast, it's an NCCT scan. What you are seeing here as white is nothing but a calcification which is occurring in the gyri of the atrophied cortex. So what I was talking about in the schematic diagram is very well appreciated here, that there is this gyral calcification which will go on to appear like this in the skull, that is the tramtrack appearance. So we have seen the skin or the dermal manifestation, we have seen the CNS manifestations. What are the ocular features? So ocular features, as we saw in VHL, there was a retinal angioma. Here there is a diffuse choroidal hemangioma. So it occurs in the choroid. And the characteristic name given is tomato ketchup fundus. So as you can see in this image, that there is this diffuse type of choroidal angioma which is appearing so red, it's called tomato ketchup fundus. There will be congenital glaucoma with enlarged globe which is called ophthalmos. So as you can see here, compared to this eye is quite enlarged because of congenital glaucoma, and this is called ophthalmos. And there can be optic disc colobomas. So what are colobomas? Are nothing but congenital defects where there is abnormal fusion of the fissures, and it appears like this on imaging. So if you compare with this globe which is smooth and round, here we are seeing this projection. So this is nothing but a coloboma. So these are the three ocular manifestations. The most important you need to remember is the choroidal hemangioma, which gives rise to the tomato ketchup appearance, and congenital glaucoma. So this is it for Sturge-Weber. Sturge-Weber is quite simple. The most important thing that you need to remember, one was sporadic. Never forget, it's S for sporadic, S for Sturge-Weber, right? So it's sporadic. The gene involved, GNAQ gene, again involves the same downstream pathways as we've been discussing in all neurocutaneous syndromes. And the three manifestations, the triad. First of all, the skin manifestation which is present at birth, the port wine stain, which can be asked as an image-based question straight away. PWS, think of SWS, right? Next, the brain manifestations, which is tramtrack calcification, which is the gyral calcification in cortical atrophy. And third was the ocular manifestations, most importantly congenital glaucoma or retinal or choroidal hemangioma, which gives rise to an appearance of tomato ketchup appearance. So this is it. So this is the end of the neurocutaneous syndrome series. We've discussed NF1, NF2, to discuss tuberous sclerosis in great details, and today we've talked about VHL and Sturge-Weber syndrome. So these are very, very important. Multiple case-based scenarios can be asked, and it covers multiple subjects. So with this particular video series, we've covered the questions which can be asked from dermat, from ophtha, from medicine, from radiology, from all these syndromes, and it's very, very important, and at least one question can be expected in the AIIMS or the NEET exam from any of these syndromes. So it's a very, very important video series that you need to watch and revise again to remember the diagnostic criteria and the manifestations in each of these. Thank you.